So, good evening, all. Good evening on a Sunday afternoon. And let's try and understand what are the updates of end of life care in India. And I want this to be a little interactive session. I don't want to just keep on speaking myself. Is everybody allowed to have a mic? Have you put any restrictions on?
Yes, no restrictions. Everybody can unmute themselves and speak and answer whatever required.
Perfect. Thank you. So, to begin with, how many of you actually are completely aware of the Supreme Court judgment in end of life care in 2023, the judgment which came in February 2023? Can some of you sort of come on screen and let me know? Anybody?
Can you unmute yourself?
Hello.
Yeah,
Hello.
hi. That?
Hi, sir. Rohan here. Dr. Rohan Paris.
Hi, Rohan.
Hi, sir. Aware about the 2023 Supreme Court guidelines?
Yeah.
So, to tell it in short, sir, they have now made two boards. One is primary medical board and one is secondary medical board. And both of them have different personnel. So in the primary medical board, there are 3 people. Two are the primary doctors from the same institution, and one is the outside.
Right. Okay. All right.
And
okay.
Yes, sir.
Your voice is gone, Rohit, but Rohan, sorry, but that's okay. So I think majority of you would have heard about that. I'm almost certain about that. It's not something which is rocket science. So it is fairly straightforward if you have a brain dead situation. The problem only arises when you don't have a brain dead situation. So again, not from Rohan. Rohan may have views which could be different and would sort of be aligned with, because Rohan works with me. Anybody else who is happy to disconnect the ventilator or who is unhappy to disconnect the ventilator in a patient who is brain dead? Come on, guys. We are not in the exam mode. We are just teaching here. If I don't understand where you guys are in your terms of your understanding, I will not be able to pitch this up. This is very important. It's not going to be written in any books. You will not be able to go and see it in any books. So I really want some participation from you. Anybody, even if it's wrong.
Sir, there is something written in the chat box also. You can check.
Let me see, where is the chat box now?
Sir,
You say that second apnea only. Yeah. Okay. Anybody else? So when is the time of death? When you prescribe somebody, pronounce somebody dead, beg your pardon. When is the time of death in brainstem death declaration?
The second apnea test.
Second apnea test. That's right. The time of the second apnea test is the time of death. So if the family refuses for organ donation consent, how many of you are happy to withdraw therapy? Come on, guys, your guys are exam going. I need to have, yes. So somebody RS, somebody says you can withdraw. Absolutely correct. I think the ethos behind this withdrawal is that if you are dead enough to donate, you are dead enough to, you're dead enough to be extubated, essentially. That's what the ethos is. So if you're dead enough to donate, you're dead enough to be discontinued on a ventilator. And that's where I think it all comes up. How many of you are aware of an advanced directive? Anybody on advanced directive? And why am I talking about it? Is it even relevant to our practice? Advanced directive, guys. So written will, Gurkirat Bedi. Written will can be can have a lot of things. Will is basically expressing your wishes. A medical advance directive is essentially something. So Bhavana says no. Medical advance directive is a legal document that states a patient's wishes for medical care if they are unable to make a decision for themselves. It is also known as a living will, personal directive, or advanced healthcare directive. I think these are all synonymous names. They interchange with each other. And really, when we talk about advanced directive in our language, we are talking about patients who have given some guidance about to what kind of a therapy they would want if they are into a situation of life and death in a hospital. Okay. So what should an advance directive consist of? It should specify the name of the guardian or close relative who, in the event of the executioner, means the person who made the advance will, is unable to take a decision or is incapable of taking a decision at that relevant time, and he or she has authorized that guardian to give consent to either refuse or withdraw medical treatment in a manner consistent with the advance directive. That is what advance directive means. And this document has to be signed. The document should be signed by the executioner, that is the person who has executed it, in presence of two attesting witnesses. They should be preferably independent. That means they should not be relatives. And then it has to be attested by a notary or a gazetted officer. And that needs to be then kept with the family. And the next of the kin or the person who is going to basically execute it needs to be aware of that and needs to be produced to the healthcare organization, doctor, person, whenever this person, this executioner, is in a hospital or needs his wishes to be basically accepted and respected. Who can make an advance directive? A healthy person who is sound of mind, who is able to communicate well, is not under any influence or is not under any constraints, should have clear instructions of withdrawal or limitation of care, should be very clearly and unambiguously written, should have the name of the guardian or the close relative who is authorized to act on the patient's behalf. So, who can have a copy of this? Who should the copy be kept with? Of course, the guardian or the close relative who is actually going to execute it. The family physician can have one copy. Local municipal or government body can have one copy. And of course, there is this ABHA, which is our digital health record, which is linked to our DigiLocker. You can actually keep a digital health copy in there in the ABHA locker. And our duty as physician is that once we are made aware of this document in a patient who is terminally ill or incapacitated, then the physician will have to verify the authenticity of this document from the local body or digital health record and then act as per the wishes of the patient. So now I would like to actually have some questions from you guys. If you've not answered any question, if you've not got any questions yet, that were you aware of this? Were you aware of the advance directive at all? Okay. So why am I saying this? Why am I bringing this in? So some reason I'm not able to get my chat box in when I'm going full screen. That's why I've sort of decreased the screen to a normal screen. Is my screen still visible, Sudeshna?
Yes, sir. It's visible.
Okay. So the reason I brought this up is because the common cause versus the government case, which actually got the judgment in February 2023, in which the primary and secondary medical board judgment was given, actually has a significant part on advanced medical directive as well. And as physicians, it is our duty to be aware that if somebody comes with an advanced medical directive, you have to actually respect that person's wishes. And let's say, God forbid, when the patient came in and you did not have that document given to you, or you could not verify that document, kindly act in the best interest of the patient. And let's say, for the sake of discussion, you have intubated that patient because that's what the patient needed. You put the patient on inotropes, and then you are made aware of this document, or you confirm the authenticity of this document, and you come to know that this is a real document. In that case, if the document says that you should withdraw life-sustaining therapy, then you will have to take the primary and medical board into the, you will have to basically, raise the primary medical board request and the secondary medical board request subsequently, and then withdraw therapy in line with the advance directive of the patients. So it is very much exactly the same if you have already started some therapy. If this medical directive is been aware to you beforehand as a family physician, or has been delivered to you before you actually started any therapy, in that case you will have to act in accordance to the wishes of the patient. And this is completely the law right now. Fortunately for us, in ICU, not many patients have made advance directives to this context, but I think in your practice, you will have these patients coming up with advanced directives and you will have to deal with them. So the board has to be included, Arnab Banerjee, even if the advanced directive is present, if you are going to withdraw life-sustaining therapy. In that case, the board has to be just formed. The board goes and says that as per the advanced directive, we are going to have an agreement that we will not be going ahead with any more aggressive therapy, and the current withdrawal of therapy will be acceptable. The family has to be discussed. Family has to accept it. Secondary medical board has to be convened. Secondary medical board gives you the same direction, and then you withdraw the life-sustaining therapy. So that's what the process is right now. It's been clearly mentioned in the document, the Supreme Court judgment. So let's go and look at the Supreme Court judgment now. How do you withdraw the medical therapy? You withdraw the medical therapy by forming a primary medical board, who then gives their judgment and forms a secondary medical board. And then a judicial first-class magistrate is just informed of the decision. And unfortunately, if the board cannot conclude, then the family has the right to approach the High Court. So let's go to the next slide. The process is same for withdrawal of advanced directives as in case where the ailment could be incurable or there is no hope of being cured. Even in case of advanced directive, if you have to withdraw therapy, you have to form a primary and secondary medical board. In patients who are incurable, the physician of the hospital actually informs the hospital and says that I don't see any hope for this patient's improvement, and I would rather want this patient to have only comfort care, which in turn initiates the board formation, which is the hospital which does that. And then this is based on this judgment, the Common Cause versus the Union of India, in which IICCM was a part, the Neurocritical Care Society, no, the Society of Neurology was a part, and the Palliative Care Society were a part. So there were three petitioners. That's why it's called as the Common Cause versus Union of India. And Union of India was the respondent. Common Cause, the registered society, was a petitioner. So what does the content of this judgment say? The primary medical board should have a treating physician and at least two subject experts of the concerned specialties who should have minimum of 5 years experience. Once formed by the hospital, they will visit the patient and give an opinion within 48 hours. So this is well within the realms of primary medical board, is within the realms of the hospital. The hospital actually does not have to go outside at all. It formulates on the request of the primary physician or on the request of the family. It formulates a primary board. Primary physician is a part of it, and there are two subject matters experts who at least have 5 years experience within the hospital who can be a part of it. They visit the family and give their opinion, and if their opinion says that yes, we agree with the withdrawal of therapy, the hospital formulates a secondary medical board. A secondary medical board, this is where it gets a little bit tricky. The secondary medical board consists of one registered medical practitioner who is nominated by the district medical officer. And there are two subject experts with at least 5 years of experience of the concerned specialties, but they were not a part of the primary medical board. That means all the 6 doctors are different. First, the primary medical board has 3 doctors. Now the secondary medical board has got 1 doctor nominated by the chief medical officer, plus 2 subject matter experts who are different to the primary medical board. So 6 doctors in total. Now, problem is that the chief medical officer in majority of the states have not nominated anybody in the country right now. The only 2 exceptions are Karnataka. What did Karnataka government say last month? Karnataka government said last month that those of you who are already been nominated to do brain death testing in the respective hospitals, they can act as a secondary medical board member, the expert on the secondary medical board. So at least those people, those neurologists, intensivists, neurosurgeons, and pediatricians or physicians or anesthetists who are already a part of the brainstem death committee of that hospital, which has already been approved by the CMO, because every brainstem death committee gets approval by the CMO of the district, you can act as a secondary medical board right now. So Karnataka has paved the way forward, but it's limited to those hospitals only which have got this brainstem death committee. So it does not constitute all the hospitals, only constitute of transplant hospitals and non-transplant organ retrieval centers. And the smaller hospitals, public hospitals where there may not be a brainstem death committee are unfortunately left out from this adoption. Maharashtra government did exactly a little bit more cursory, but more or less same. They said that those government medical colleges which have got a brainstem death committee, they can actually have experts sent as secondary medical board. Please send those names. We will nominate them as a secondary medical board member. So it's only applicable to the government medical college in Maharashtra. Rest of the private hospitals, other district hospitals which do not come under medical college category are been left out. So we have a very fragmented adoption by 2 different states, but at least there is a start somewhere. It's not like we have left into a complete lurch. There is a start somewhere. Other states should start adopting it. Why does this need to be adopted by the state? Remember, the Supreme Court judgment is actually applicable to every state of the country and every citizen of the country. However, state and health are basically joined together because health is a state subject in our country. So anything regarding health, the state has to adopt, whether it's a Government of India resolution or whether it's a Supreme Court of India judgment or a High Court judgment. The state has to adopt it officially and put up a process to actually implement this judgment. So once the state adopts it and judgment is implemented, only then you'll be able to withdraw therapy in your hospitals. Now, the secondary medical board is supposed to give an opinion within 48 hours as well. If both the opinions have been understood, first opinion taken, primary board opinion taken, family agrees to it, secondary board opinion taken, secondary board opinion is in line with the primary board opinion and the family agrees to it, or the guardian nominated agrees to it, then the judicial magistrate of first class, which is JMFC, is just informed and you can actually go across and withdraw life-sustaining therapy. Now, let's say there is no consensus. Either the family doctor feels that WLST should be done, or the family feels that WLST should not be done, or vice versa, whatever it is. Either of them can approach the High Court. The court will appoint a 3-member committee of medical experts in the field of general medicine, cardiology, neurology, nephrology, psychiatry, oncology, with experience in critical care, with medical profession standing of at least 20 years of experience. So these 3-member committee will be then formed, will independently go and actually assess. State of Odisha has also put out this Government of India guideline to sort of try and adopt this, which is very, very recent, but we still haven't got an official adoption of the policy from state of Odisha. So a lot of states are going for that. A few months ago, we had these guidelines for withdrawal of life-sustaining therapy put up on the website by the Ministry of Health and Family Welfare, Government of India. I did certainly go and comment on it. Unfortunately, a lot of people did not comment on it. IICCM has gone and commented on it, I believe, but I don't have the draft of what they have written. But I believe this is the start. Just like you have a quality of life, there should be some dignity of death. No longer should your patients wait for some lawmaker to come and tell you that you have to do the right thing for the patient. Your heart knows what is right thing for the patient. We cannot be flogging them on ventilator or on inotropes, waiting for some lawmaker to tell us what is the right thing for the patient. It's unfortunate, but that's how the country is basically placed in terms of legal matters right now. You go to any other developed country, whatever guidelines are put out by the professional society, for example, IICCM, Cardiology Society, Neurology Society, in their respective fields, they are taken up as sacrosanct, and the courts and the government actually go across and adopt those guidelines without any change. Here, there is a big push of not adopting the professional society guidelines, but government wants to make their own guidelines, which is perfectly fine. They try and take some medical experts as well. But a lot of the time we rely on official judgments from the courts to actually give us a direction. And this is what happens. If you have a direction given, then court has set up a process. And then most medical doctors have a anxiety of following the process, and the process has to be adopted, process has to be set in by the state government to actually follow at a universal level, not just in public hospitals or transplant hospitals, but in all the hospitals across the state, which doesn't become the reality. So I strongly urge you that you should do the right thing. Maharashtra basically became the first state to implement Supreme Court's right to die with dignity directive. Karnataka is the second one. But again, as I said, should my patients wait? Absolutely not. No more suffering. You need to you need to, as intensive care specialist, you need to essentially go and approach your local body and have them one specialist from each specialty in your hospital nominated to be a part of the secondary medical board, so that whenever the decision comes in, it can be implemented. And let's remember, it's all binding on us. It's the Supreme Court of India decision. We are not different. We are not left out from that decision. We are very much a part of the decision. And in fact, if we don't act in the right way of implementing that decision, and if somebody goes against us and says that despite trying to put up a primary medical board, secondary medical board, the doctor is not willing to be a part of it, the High Court, which is where the appeal will go, will actually take a cognizance of it in a very bad way, and we could be reprimanded for that. So I think if something like this comes to you in clinical practice, immediately ask the hospital to formulate a primary medical board and write a letter to the government to nominate a specialist for the secondary medical board. Do not wait. This is now a judgment, which if we don't implement, it will actually come back biting to us. So thank you very much. I'll stop sharing. You can put up your cameras or your requests, and you could tell me if you have any questions before we go to the next topic.
So there's anything in the chat box and other? Sir, I was sorry, I was driving. I've joined.
No problems. No problems. So very silent crowd, Arindam, today. Nobody is speaking today. Maybe you've taught them a lot in the week.
No, not that. Most of the times, people expect the others to speak.
Yeah.
But in exams, you are on your own.
I just think that this is a topic which no book is unfortunately going to tell them. This is a topic which they will have to sort of read from papers, read from judgments, and that's how it will have to be formulated.
I think one question.
So, yeah. So now,
conflict
Tom is asking, kindly give a short idea about kind of question we can face in the practicals in EOLC department. I think this will definitely be a question in the EOLC department, even if you are doing a normal long case. And if that case unfortunately turns out to be somebody who is very, very sick in multi-organ failure or who has got a very poor prognosis, the examiner would definitely ask that, would you like to talk about end of life care and what are your thoughts on end of life care? And if your thoughts are very clear, your thoughts have to be that end of life care is just as important as treatment for the patient. Once the consensus for futility amongst the treating physicians, whoever are involved in the care, including the nurses and the healthcare staff who are caring for the patient, is quite obvious, it is our duty as physicians to actually raise the primary medical board request with the hospital administration and speak with the family regarding the same. If the If the hospital administration does not put up a board, you need to give it to them in the writing. They are bound to do that. The secondary medical board, of course, is not completely in hospital's hand. Two specialists in the secondary medical board are from the hospital, but they will have to wait for the CMO to nominate either somebody from their hospital or an independent person to be sent from outside. But you should be aware that this can be basically something which will be asked for you absolutely certainly. As long as you know the process, I think the examiners will be more than happy. I can assure you the examiners are completely well versed with this process right now, and they will definitely come and ask you about this in detail. Now, conflict in prognosis, board can only be made after futility criteria certain. No, the board can be made if the futility seems to be the likely outcome or the terminally ill seems to be the likely outcome. The opinion of the 3 doctors on the primary board is very important. They will come and they will independently review this patient. And if they find that all the 3 of them have a concurring opinion, then they will speak with the family as well. And the family has to consent as well before the secondary medical board can be called. Okay, so it's not just for futility, but yeah, generally for futility is what you would call a primary or a secondary medical board. And of course, for advanced directives, there are clear advanced directives which come to your notice afterwards. Sorry, if the advanced directives come to your notice is another reason why you would want to call up the secondary medical board, sorry, primary medical board. You may not agree with the futility in that case, but if there's a clear advance directive that I don't want to be on a ventilator, and unfortunately you've already put the patient on ventilator and you have now come across this document which says advance directive and you verified the document, then you will have to call the primary and secondary medical board and withdraw the ventilator. So please be very clear about it. Do not have any doubts. If you have instituted a therapy right now in our country, which needs withdrawal, active withdrawal, whether it is inotropes, whether it is dialysis, whether it is ventilator, where you're actually going to pull something out of the patient or stop something actively for the patient, then you will have to have a primary or primary and secondary medical board put up, even in case of advanced directive or in case of futility. Now, you may ask me a question, what about antibiotics? What about fluids? I don't think stopping antibiotics actually stops anybody's heart immediately, but stopping inotrope will, pulling out the dialysis catheter will, pulling out the ventilator tube will cause an immediate imminent crisis where the patient may die or succumb to that action. Hence, that medical directive has to be coming up with a process, and the process currently is what we just discussed about. Now, Soham, you are wanting to have some insight about DNE and DNR orders. I think when the primary and secondary medical board has been formulated and there is clearly an understanding that you will be withdrawing life-sustaining therapy, automatically there is a consent for DNE and DNR. So do not intubate, do not escalate orders are more or less the same. They are do not resuscitate, do not escalate, the orders are more or less the same in terms of the court. The court says that you may either withhold or you may withdraw. Both carry a active action from your side where you are not actually allowing a process to happen, where you are sort of not having escalation of care, or you are writing it as a withdrawal of care when you are doing WLST, which is in DNR. So both of them carry a lot of importance in the eyes of the court. And currently the ICMR document is the only document which says do not resuscitate. If the family or the patient clearly says that I do not want a care beyond a particular point, there is no way you can actually force a care, and you can easily say, do not have a escalation of care from the current level, document it currently, that what care is the patient taking, and then you do not increase it as per the patient's or the family's wishes. So that's how you need to document that very clearly. There is absolutely no fear in doing a DNE. DNR orders as per the ICMR guideline can be given. And of course, if you're doing a primary and a secondary medical board, if you're following the Supreme Court's process, it's a given that you're not going to resuscitate this patient because you're actually withdrawing the life-sustaining therapy. Ronak Patel says EOLC protocol versus financially exhaustive relatives taking patient home and electively removing support. Legality and things to consider at our side. Ronak, this is currently unfortunate and a sad situation. This is precisely the reason why futility is being discussed at deeper lengths. And if you think that this patient who is financially exhausted has no meaningful life or is terminally ill, then please have your primary medical board constituted. If you don't agree with that and you feel that this patient is just financially exhausted and essentially can still have a meaningful life, in that case, it is your prerogative to actually shift this patient to another hospital where treatment can be continued. What they do after leaving your hospital is not your problem. But if they are leaving from your hospital saying that we are going home on a ventilator, and you don't agree with that this patient is terminally ill and would not make it anyways, in that case you are in trouble, because the court is very clear about it, that if financially somebody is weak, then it is your duty to actually transfer this patient to the hospital where they may be able to get treatment. Any other questions?
Who is going to give the idea of EOLC, doctor or family? One question has come.
So both of them can bring it up. Absolutely. It is the primary physician's responsibility actually to bring up the idea of end of life care. If the primary physician is convinced that they have done everything possible, and despite that, the patient's outcome seems to be terminal or likely to be terminal. That's what the judgment says very clearly.
One more question every time people do ask, and also whether it could be asked in the exams. Advanced directives, is it legally tenable in India?
Yeah, we just spoke about that.
Okay.
In fact, this Union of India versus Common Cause judgment has got a very long document on advanced directive. Let me see if I have that document. I may be able to just show it to you. Supreme Court judgment, because it has
in the meantime, sir, if there is so that if there is an advanced directive.
Yes. Arindam, I lost your voice. Hello?
We also can't hear them.
So that's
Yeah.
now audible?
Now audible, yeah. Now audible.
Yes.
So if there is a conflict between an advance directive of a unconscious patient and the family members, which one will take precedence? Whether the or can we overrule? Can a family member overrule a clear advance directive?
The family members cannot overrule a clear advance directive. If there is an advance directive which comes into your notice and you have verified that it is the right directive, you have to then formulate the primary and secondary medical board. That is exactly what I'm trying to say, that it actually gives you immunity. 6 independent doctors come and agree to it, and then the patient's wishes will be actually of paramount importance, and the court will agree to that this, in view of the patient's wishes, we are continuing with the advance directive as it has been talked about.
Though, and last question from my end, just to give them clarification. The withholding of support, not active withdrawal, which is more of a passive process, should that be also always documented and
100%. It has to be documented very clearly, because in the eye of the court, withholding and withdrawing, they have almost given same importance. You are actively not giving anything to the patient. That is also a thing which the court says that you should be writing and documenting it in the same way. But it does not have to have a primary and secondary medical board for that, because that's linked with the wishes of the patient. And if the patient's wishes are not known, the next of kin needs to express their wishes on behalf of the patient, and you need to document that. Unfortunately, I'm not able to find the judgment. Maybe.
Sir, we can share later. No issues. We have a group.
It's on my hospital laptop, perhaps. So
We will share it later. And last one question: if the doctor feels that that patient can survive, is this an obligation for the doctor to follow advance directive still, or the doctor can overrule in along with his medical judgment?
Advanced directives are very clearly the expressed wishes of the patient. You cannot overrule the patient's wishes, provided they are explicitly been written in simple language, which is easy to understand. If a patient writes, I do not want to be on a ventilator, and if I am on a ventilator, then please remove me from the ventilator. You will have to formulate the primary board and the secondary board, and you will have to remove this patient from the ventilator. Simple.
Fair enough. I think we have answered most of the questions.
You will have to obviously, you are not going to give atracurium and remove this patient from the ventilator. That medical judgment has to be there. If you're going to remove this patient from the ventilator, you will stop, you will plan it as an extubation. And you may perhaps give them as a bridge to NIV and then let the patient wake up. If the patient doesn't wake up or is unconscious completely, you will give the best possible chance that I'm going to extubate while the patient has got some breathing effort or a good breathing effort. So that judgment, that granular judgment, that doctor's responsibility, do no harm, will always be there. You cannot be blindly saying that I'm going to give atracurium and I'm going to extubate for the patient.
I agree. We have to very skillfully apply both the principles of patient autonomy as well as do good and do no harm. Right.
Yes.
So that's how you can circumvent the issue itself. I think we have answered all the questions. You can proceed for the next session.
Next, what do you want me to talk on? Is there anything else you want me to talk on? What is it that you wanted me to talk on apart from EOLC?
No, I think you've covered the medical legal ethics and ULC related to the ULC. Anything the candidates wish to, you have got a good opportunity to ask from Dr. Pandit. He is constantly working with the Honorable Supreme Court, the central government, Maharashtra government to bring on certain aspects of critical care, which have till this time had some grayer areas, which we are trying to get better on this. DCD, sir, DCD you are going to cover a little bit?
I just thought people should know what is DCD, and I will cover a little bit about brainstem death, sir, ideas also. I think I spoke last time about it, but I might just again have a little.
Yes, I think that would be rightly done,
that's
sir.
another subject which a lot of books will not cover very well for you.
Okay.
So if you, and I'm going to keep it like this so that I can see the chat box. Otherwise, I'm not going to see the chat box, unfortunately. So somebody wants to know counseling, bad prognosis and medical error, procedure error. Okay, I'll come to that after we finish this, Ronak. So let's quickly finish about DCD. Now, how many of you actually know what is DCD? Donation after cardiac death. And how many of you agree that we should be doing DCD in our practice? Anybody on the chat box? Anybody on the microphone? So Dr. Vishal says no. Anybody? Never seen. Have you heard that it can be done? Okay.
Yes, sir. It's done in the abroad countries where the deceased donors, because of the lack of the easy availability of the.
So even we have a very poor availability of organs, isn't it? But I can assure you, is that Dr. Shweta who is talking?
This is Dr. Urvi, sir.
Sorry, I'm not able to see you guys. So, and I'm not able to read the. Okay, anyways. So, Dr. Urmi, I'll tell you one thing. I will almost assure you that even in your hospital, you're doing donation after cardiac death right now. You will all be surprised. You do it every single time it's been done. Tell me how many of you have had a request for eye and skin donation after the heart has stopped?
Yeah, a lot of time from the families for the cornea
Every
donation.
single hospital, right? Even at home, people go and do a eye donation and skin donation, correct?
Yes, yes, sir.
Something which is so easily acceptable for last 30, 35 years from what I remember, the eye donation has really picked up. Skin donations in the last 5-10 years has picked up, but it's not uncommon to have a request for eyes to be donated. You see advertisements of eyes donation in theaters, on television sometimes, on hoardings sometimes. Skin donation advertisements don't come across, I agree. But Netradan, some actress decides to donate eyes, it becomes a big news. Some actor decides to donate eyes, it becomes a new big news. Right now, the IPL, the cricketers are actually putting out a cry for organ donation. Have you heard that? Have you seen those videos?
Yes, yes.
Yeah, so I'm sure you've seen those videos. So trust me, donation after circulatory death is something which has been going on for a long time. So let me just take you through a little bit of history. If you look at death, it's been described in various ways. So apnea, unresponsiveness, immotility, immobility, following that the decay of the body, which happens. Some people say the spirit has departed. There is immense cultural, religious, and mystical significance to death, which is basically been there since the Renaissance time. So it's not something new. Even right now, we talk a lot about life after death. All religions have got particular rituals to do light after death. Hindus put up a light in the house. Some other religions would be doing something different, but they all believe that there is something by the continuum after death, and that is why the death has got a very important significance in most of the religions. But if I tell you that the first time actually the description of death was given, it was given by a gentleman called as William Harvey rather. He sort of in 1628 said that the heart is the principle of life, from which heat and life are dispersed to all parts of the body, and death occurs when heart and circulation stops. That's what Harvey mentioned, and I think a lot of us would agree to what Harvey said. Of course, no doubt about that. There is very little doubt that what Harvey said makes absolute sense. Anybody knows what is the definition of death in India? Anybody? Can you put up in the chat box if there is a known definition of death in India that you know of? Has death been defined in India legally? So process of cessation of life. So Gurkirat, you're again saying something similar to what Harvey says or what everybody else says. I'm asking, is there a legal definition of death in India? Have you heard of it or you are not aware of it? So Nimit Gandhi says permanent cessation of circulation. Some people are saying no. Look, guys, why don't you just put out your speaker and say yes or no? It's difficult for me to keep on reading your chat box. It's just not, I'm not enjoying this at all. I want a vibrant discussion. I want a vibrant discussion between you guys.
Sir, JAPI papers were heard which were regarding the brainstem death, not a brainstem death, cardiac death, but even then there was not a clear cut. They've also written permanent cessation of life only.
Okay. So the Human Transplantation of Human Organs Act, THOA 1994, which is the Government of India Act, actually has defined death very clearly. And this is the definition of death, which is not my words. I have just copy and pasted it, cut, copy, paste. This is deceased person means a person in whom permanent disappearance of all evidence of life occurs. This is exactly how they have mentioned in the Act. By the reason of brainstem death or in a cardiopulmonary sense at any time after live birth has taken place. Brainstem death means the stage at which all functions of brainstem have permanently and irreversibly ceased. Okay, so it defines death in cardiopulmonary sense as well as in brain death sense. And in brain death sense, it defines brainstem death. So in India, we follow brainstem death. We do not follow any other part of the definition. We do not go for a whole body death. We follow brainstem death. And if you look at DCD, eyes and skin are already established, and we are very comfortable in asking eyes and skin. In fact, families come across and ask for eyes and skin to be donated. So it's not something which is difficult. in fact, if I look at it, donation after cardiac death is a viable option to honor the patient's wishes. And it should definitely be considered as an excellent end of life care for any patient who has suffered a catastrophic neuro event but has not progressed to brainstem death. And I believe it is our responsibility as doctors to offer donation after cardiac death to these patients. I will come you how it can be legal and how it should be implemented. So I'm sure all of you are aware of this Maastricht criteria. Anybody who is not aware of the Maastricht criteria, can you just tell me? Come on the microphones. You don't have to switch on your cameras, but talk to me, guys.
No, sir.
Sorry?
Not heard of it, sir.
Not heard of it. That's fine. Doesn't matter. So I'm happy that you spoke up. So Maastricht is a place in Holland, and they defined criteria for donation after cardiac death or donation after circulatory death. And they put up 5 different criteria in which a circulatory determination of death can happen. Okay, so donation after circulatory determination of death, also called as DCDD or DCD in simple words. So it's category 1 to category 5. If you can see you're able to see my slides, right?
Yes, sir.
Yes, sir.
Category 1 is dead on arrival. Now, unfortunately, if you have a person who is dead on arrival, you don't have any control over it, right? You don't have any control. The death may have happened 10 minutes ago, death may have happened an hour ago. So forget about the right side column, feasible, where feasible. We are not going to go into that right now. The second would be you have a patient who comes to ER and has an unsuccessful resuscitation. Again, that's an uncontrolled scenario because you're trying to save the patient's life. And unfortunately, you cannot save when you pronounce the patient dead. Third would be an anticipated cardiac arrest. Now, this is more of a control scenario where you have a control. You're anticipating that this patient would have a cardiac arrest. And let's say if you are able to withdraw life-sustaining therapy in such a patient who is terminally ill, you may have a better control situation where you could actually do a donation. And fourth situation is that you have a patient who is brain dead. 2 tests have been done. Consent for organ donation is already obtained. And while waiting for the organs to be retrieved, the patient has a cardiac arrest. You wouldn't have slightest of the hesitation to rush this patient to operation theater, provided there is a surgeon there, and quickly take out the organs, because anyways the consent was done. So category 4, I think, is very easy. And category 5 is an unexpected arrest in an ICU patient where you were not anticipating a death to happen. Again, that's an uncontrolled situation. Now, if you just concentrate on category 3 and category 4 for me, and perhaps category 5, and come to this deceased organ donation definition, deceased donor donation definition, it very clearly says that if you have a person who has died in a cardiopulmonary sense at any time after live birth has taken place, and this is a transplantation of human organ act definition, already 1994, 30 years ago, the government had made a provision for us to actually do DCD. We are waiting for the Western world to show us the way, but the government of India had actually put into the act in 1994, 30 years ago, that you have a right to go across and do an organ donation in a patient who has already got a circulatory death. Forget about brain death. So legally, it is absolutely acceptable to have a patient who is having a circulatory death, and you can take the organs from them. Now, how would you do it? That process, I'm just going to go through it. What is feasible in India? Class 4, as I said, somebody who's brain dead, awaiting organ retrieval, for sure. The discrepancy here is if the first test is done and the second is not done, then should you do it? And then should you be doing antemortem cannulations, because you may want to have the viability of the organs. I think we'll come to that in a minute's time. So it is technically feasible now that you have a withdrawal of care for futility, which we just discussed in the previous talk that we discussed. Now, if I have a withdrawal of care which is planned, primary board done, family accepted, secondary board done, family accepted, judicial magistrate informed, And now I can say that I am going to withdraw the ventilator at 11 o'clock. Let's say for the sake of discussion, 11 o'clock in the morning. And I discussed this with the family and asked them that were there any wishes of the patient to be an organ donor. Now on the license also of many states, including Maharashtra and Gujarat, you can actually write your wishes whether you wish to be an organ donor or not. That's somewhere you can actually put up your wishes right now. It is completely legal to do that. The license comes out printed with whether you want to be an organ donor or not. So it's a new thing which has been implemented for last 2 years in Maharashtra as well as in Gujarat. And I think Rajasthan is also doing the same thing now. So 3 states in the country will have this on their license. Newer licenses or renewed licenses will definitely have that question, which you will have to answer. You can, of course, it's not mandatory to answer. You can leave it off as an option, but you can answer yes or no. You can let your wishes know about it. And let's say for the sake of discussion, either the patient had said yes during his lifetime, had expressed a wish to be a donor, or the patient's wishes were not known, that the family is very keen for donation. Then in that case, you could actually activate it in the same way as you would activate a brain dead donor. Inform your local transplant agency, ZTCC or Transtan or Noto or Roto, whichever is active in your state, whichever is the appropriate authority in your state, and say that I have a DCD donor. I am going to withdraw therapy at 11 o'clock in the morning. It's been all done, primary and secondary board done, family have accepted, magistrate informed. Family is very keen to withdraw the life support. We are doing it as per the legal action. However, the family has also expressed the wish for organ donation. And I think liver is viable. I think so-and-so organ is viable, whatever it is. Then the organ donation agency will get into action. They will inform the relevant teams. The relevant teams would assess the organs. Relevant teams would actually inform the donor, the recipients in waiting list. The recipients will be called, provided they accept the call, and then you will have withdrawal of life care at 11 o'clock. Now, let's come down to the process. So when the withdrawal of life care happens at 11 o'clock, what happens? Okay. So this committee, I've already gone through the committee. This is the paper, this is a joint position paper, which we actually published. I was one of the authors on this, and this was endorsed by so many societies. ISOT, Indian Society of Organ Transplant, ISCCM, SNCC, Indian Academy of Neurology, Indian Association of Palliative Care, Liver Transplant, Heart Transplant, Lung Transplant, Academy of Pediatric, and Critical Care Chapter of Academy of Pediatrics, and Indian Society of Nephrology. In fact, the ISOT and ISCCM did a simultaneous publication of this paper in their respective journals, the IJCCM and ISOT journal. And we actually had these documents a part of the whole process, and we laid out the process into ways in which it can be done. So let me just go across to the ways in which it can be done. I will come back to a few communication parts later on. So the ways it can be done is the treating team determines futility. The hospital constitutes the primary and secondary medical board. Primary medical board opines WLST and refers to secondary medical board. Secondary medical board then is in the favor of WLST, informs the judicial magistrate. Then the treating team refers to the transplant coordinator who discusses about organ donation. If the family is for organ donation, then the treating team performs the WLST and organs are retrieved. And you may have a choice of either doing a normothermic reperfusion or ex vivo perfusion. Now, this is actually the process which we do. We withdraw therapy here. Let's say WLST is at 11 a.m. Then you've got an agonal phase till the asystole happens. Your time starts, your important time starts when the systolic blood pressure touches 50 millimeters of mercury till the time the death happens, the asystole happens. So how long is this time actually determines which organs can be taken. If this time is more than 60 minutes, majority of the organs may not be viable to be taken up. If this time is less than 60 minutes, then liver, kidney, and lungs perhaps can be actually donated. Liver and kidney can definitely be donated. Once the asystole happens, there's a 5 minute of no touch time where you declare the patient dead, do a ECG, do a clinical examination, and give family to have 5 minutes with the patient. And then you determine death and you push the patient to operation theater, where the organs are then preserved either by doing a cold flush through the venous axis, or sometimes you may do a normothermic reperfusion. It's not compulsory to do a normothermic reperfusion, and I'll come to what normothermic reperfusion is. And then this brown arrow means that the organ donation actually happened. So the warm ischemia time is from asystole to the organ preservation. From organ preservation with the cold flush or the NRP starts the cold ischemia time. And your functional warm ischemia time is really from the time the systolic blood pressure hits 50 till the time the organ preservation is there. So if this time is less than 60 seconds, 60 minutes, then this time is definitely very, very short, around 10 to 15 minutes, and you can actually go across and donate the organs of these patients. I have been a part of many DCDs in Australia, and what we used to do is we never would go across and put a normothermic reperfusion. But since 2010 that I'm back from Australia now, and I only go once in a week, once in a year to work there, and seldom do I now see DCD happening when I am working. But even there, now they have started thinking of normothermic regional reperfusion. So what you do, you put an antemortem cannula in the femoral vein and femoral artery, and you could have a circuit which is primed with the patient's donor blood, which is kept ready. And as soon as the death happens, you could start ECMO. And how does the ECMO start? You put in an aortic balloon and you occlude the aorta at the level of the diaphragm, and the other femoral artery and other femoral vein basically start at the ECMO, so that there is no perfusion going to the heart, there is no perfusion going to the lungs, there is no perfusion going to the brain. So you are able to retrieve visceral organs because visceral perfusion is being maintained, where the aortic balloon actually clamps out any flow going up. So you don't have a perfusion going up into any of the thoracic or the cerebral organs, cranial organs. You only have a regional thoracic abdominal perfusion going on. The second way is you could actually do a normothermic reperfusion. A normothermic reperfusion is you use a normothermic reperfusion fluid. It's not blood, it's fluid. It's exactly like a CP bypass. You quickly do a sternotomy and put a venous and arterial cannula in, and then you, through this reservoir, drain out the blood. And then this fluid here, which is number 4, is a gas mixer and your heat exchanger, which allows you to have oxygenated fluid going and a little bit of blood going through, and you allow the fluid to go through into the heart, and you establish your circulation, which is normothermic regional reperfusion, which is using a fluid. Now, normothermic machines are available. They may utilize blood, or they may utilize blood with fluid, or they may utilize only fluid. It all depends on which protocol you're following. But it is essential that you are able to at least preserve this organ longer, and you may be having a better outcome in these patients. There are now many trials which have looked at organs donated in a BSD versus organs donated in a DCD, and the results are almost comparable. Either ways, the organs have got a good viability when they are transplanted. A few things about asking for organ donation here. So generally what I used to do is, when I used to have a DCD as a process, and if I was doing a WLST, I would start asking the patient's family. In Australia, it was easy because the donor information on the license is accessible by the hospital. The hospital will actually go across and have a look on the license without even family knowing about it, that what the expressed wishes of the patient were. And if I was aware, then I would say that we have found out that the license actually he or she had mentioned yes for organ donation or no for organ donation. If it was no, then we would of course honor the patient's wishes. If it is yes, then we would ask for the consent from the family. And 99.99% of the times, I have not come across a family who would actually say no when the wishes of the deceased or a patient were known. If there was no information on the license, then I would start off by asking that eye donation is a good way to start developing the rapport. Conversation becomes easy. And then once they are accepting and willing for eye donation, then you need to take up a pause, go out, come back and say that, by the way, you could also think of donating other organs, because that's a possibility, because now we are doing a withdrawal of life-sustaining therapy. I think that kind of a discussion is very staged. It makes the family take some time. You could actually initiate a similar sort of a discussion when the patient is brain dead as well. And same discussion can happen. Now, what should be the way you should communicate? Always take your bedside nurse with you and one colleague. Ensure privacy. Identify members who are present. Make sure there is some continuity in the family members who are attending this meeting. You don't want to meet a completely new set of family members. You need to have people who you have been talking before. Use simple words. Do not use the medical jargons. document clearly, often in the same words which the family member spoke or you spoke to them, so that exactly the conversation is actually documented well. Never ever make a conversation like this at the bedside. Always be it in a quiet room. And if you have not examined the patient before, please examine the patient before you actually go in, so that you know exactly what is the latest situation. If you do not prepare yourself, you are planning to fail. So if you don't plan this meeting well, you are planning to fail. Prepare your settings. You need to do it in a private setting, not on the bedside or in your cabin. It has to be an independent, neutral room, and be prepared with all the information of the patient. Now, a couple of things I would like to talk about. I think I spoke about it the other day. I don't remember whether I actually discussed it in greater detail or not. I would like to know from the crowd, when does a patient...
Just one thing, Dr. Pandit. What are the organs that are not cannot be transplanted from a DCD person?
Dr. Arindam, now almost every organ can be transplanted except brain. So people have now transplanted heart, they have also transplanted lungs, they have transplanted abdominal organs, they have transplanted tendons, they have transplanted tissues, hands, everything can be transplanted from a DCD.
Pancreas, gut, and all other. The conventionally it was taught that then DCD, heart and lungs may not be in the best shape, but I think we have circumvented that.
The NRP actually circumvents that. Ethically, a lot of people have a dilemma because you're waiting for the heart to stop. Then you take that heart out and then you put it into somebody else's body and you let it start again. So there has been a lot of ethical dilemmas about heart and lungs, especially. For lungs, you need to actually intubate this patient again. And I've gone through those times when anesthetists were extremely reluctant in Australia in late 2009, 2010 to re-intubate these patients for the lung retrieval, because you need the lungs to be having some amount of residual volume there. You can't have a completely collapsed lung. So they used to re-inflate the lungs, give a couple of breaths with the ambu so that the lungs inflate, and then they would do a cross clamping and take out the lungs. And anesthetists would have a lot of ethical dilemma doing it. So look, I think every country goes through this phase. Now, Australia could do it in 2007, 2008. UK did it a year or two before that in a larger scale, because for last 20 years before that, they were actively withdrawing life-sustaining therapy for futility. Now here, unfortunately, what has happened in India is that a lot of organ transplant champions or transplant team have now thought that this Supreme Court judgment actually gives them a pathway for DCD. And I am completely against that. I completely say to everybody that yes, it will give you a pathway for DCD, but before that, you need to do several withdrawals. Now, each person's comfort level will be different. Somebody may be comfortable doing 10 withdrawal of life-sustaining therapy before approaching this as an organ donation process or a pathway. Somebody may want to do hundreds of them before they are comfortable doing it. Now, countries like UK and Australia, we can't just leapfrog and say that now from today onwards, every time there is going to be a withdrawal of life-sustaining therapy, I'm going to ask for organs. That's not right. It's putting our doctors into a lot of pressure, a lot of ethical dilemmas. So let withdrawal of life-sustaining therapy become a everyday job, just like EOLCs right now, with majority of us doing EOLC very comfortably. Let withdrawal of life-sustaining therapy, as per the Supreme Court judgment, become a norm in patients who have futility, in patients who are terminal. Once we have reached a few years into that, automatically DCD will be a byproduct of this process, but not right now. We can't be utilizing this for doing DCD right now. I think it would be unfair on our medical health system, on critical care specialists, to actually do this. And the organ transplant agencies which are vouching for this need to be put on silence. And I've done that in many forums. I've said this is not the right time to actually talk about DCD as a process, as a parallel process to withdrawal of life-sustaining therapy.
Is there any institution who are presently doing in DCD in India?
3 institutes do it. 3 institutes have done it. 2 are doing actively. PGI Chandigarh does it. IKDR in Ahmedabad does it, and GMC Nagpur has done one. So they have done, but all these are public institutes or a trust institute. None of the private hospitals have done it right now. So I don't know the validity of these three institutes because they have not gone through the controlled category of Maastricht. They've actually gone into uncontrolled category where they have been an unsuccessful resuscitation. They've asked for the consent of the family member. They've continued the CPR using either a Lucas or a auto pulse and then taken the patient to theater, instituted normothermic reperfusion or ECMO, and then gone ahead with a donation. That's the process they are doing. I would be very uncomfortable doing uncontrolled things. That's just my personal view. Certainly, it is nothing illegal in that because there is a category which is there, and as per our TOHA Act, after the heart has stopped, you can donate. But ethically, I am not prepared for that right now. Even as after having doing so many DCDs and so many brainstem declarations, I must have done more than 150 to 200 almost. And DCDs, I must have done at least 30, 40. Even after these many numbers, I still feel uncomfortable approaching a family in whom I couldn't resuscitate a person, and then I talk about DCD. It is something which I have not come across in my own sense to cross that bridge yet.
Sir, if the patient has previously wished for a donor after DCD, but family does not consent, so in that case, sir?
So again, unless there is an advance directive, who asked this question? Sorry, what's your name?
Dr. Arnab, sir.
Arnab. Arnab, if the family has said no, but the patient had said yes, is that what you're asking me?
Yes, sir. Yes, sir.
So if there is an advance directive to that, in that case, you could sort of overrule and say that we would like to go ahead. If the advance directive says that I would want my organs to be donated, but in absence of a clear advance directive explicitly written that I want to donate my organs if I am brain dead or if there is a DCD with me, in that case, you will have to go with the family's wishes. You cannot go and say that I'm going to go with the patient's wishes. Even in Australia, if the patient had said yes on the license and the family would say no, it was very clear for us, it is a no, because the consent is given by the family. Unless it's an advance directive which is notarized and legally produced, then only you can actually overrule. And I hope that we don't fall into that situation anytime, because it would be ugly. You will be bound legally and ethically to honor patient's wishes, but the family would be completely against you. So it would be a very difficult situation for an intensivist. Even for the hospital, it would be extremely difficult. And most of us would take the path of least resistance, which is just go with the family's wishes. Because the donor is not going to come and sue you, but the family will come and sue you. The donor, unfortunately, is dead. Okay, so I will just talk about a little bit more in terms of death. So again, I want to just forget about my presentation. I'm going to stop sharing the presentation, and I'm going to sort of understand from you guys. When do you see say a person is alive? Can anybody come on the mic and talk to me? When do you see there is life? Anybody?
Kindly answer, please. You're almost 40, 45 people are on board.
Anybody who says that I would say a person is alive when these criteria are met?
Sir, if if you see the definition of death, like you just mentioned, then if there is no circulatory arrest or if there is no brainstem death,
very good. So
then
absence of
the person
brainstem
is
death
alive.
and absence of circulatory arrest, you would say life is there, correct?
Yes, sir. Yes.
Now let me ask you a question, Rohan, and not only you, everybody. When a child is born, right? When we are all born, if we do an ultrasound of an expecting mother today, which week would you hear the heart sounds, or you would be able to see the heart sounds? Which week of pregnancy? Anybody on this? 5 to 6 weeks.
5
Correct?
to 6 weeks.
5th to 6th week. So do we celebrate the birthday of the child in the 6th week of pregnancy of the mother?
No, sir.
No. When do we celebrate the birthday?
The child is born.
What's the difference? The circulation was there as per the definition. So why are we not considering that the birthday was then? What happened on the day the child was born, which was different?
A spontaneous breath, sir.
Breathing, sir.
Absolutely
Sir,
correct.
breathing started.
Perfect. So life is breath, nothing else but breath. And if breath is not there, life is not there. That is why in the brainstem death testing, apnea holds such a big importance. What was happening when we were all surrounded by our mother was the umbilical cord was the ventilator for all of us. Agree? It was providing the oxygenated blood to us. And that's how we grew inside our mother. Correct?
Yes, sir.
Yes, sir.
Yes, sir.
Right. As soon as we were born, the umbilical cord was cut and we started breathing. And when the patient becomes brain dead, ventilator becomes the machine which is providing that oxygenated blood to us. The circulation was still there. Circulation was in the mother as well. The circulation is there when the patient is brain dead as well. But there is this artificial ventilator which is supporting it. And that's why apnea test is so important. If you explain this to the family members, they will quickly understand what life and death is. The biggest problem about our consent for organ donation and hesitancy of doctors to actually talk about brain dead, including neurologists and neurosurgeons, is they are not able to convince the family member that the patient is dead. We talk about legal, we start taking the support of the legal definition. We say legally aisa hi hai, legally vaisa hi hai. Nobody tells them that life means breathing, and we are detecting whether the breathing is there or not by doing a brainstem death testing, including apnea test. And trust me, guys, every time I've said this to a patient's family and I've done the counseling, majority of them have said yes for organ donation. And I'm not talking about a few numbers, I'm talking about hundreds of them. And on top of that, if you look at, if you are able to take the person, a family member, in the patient's room while you are doing a brainstem death testing, and you actually allow them to see the testing, sit with the patient while you are doing the testing, they realize it better because they see that the patient has been disconnected from the ventilator, and despite 7 minutes, 10 minutes, 15 minutes, whatever time the CO2 takes to rise up, the patient does not have any spontaneous breathing. And the penny drops and they actually realize and accept the death very quickly. The second problem with doctors is we talk about medical jargons. We say we are going to test the medical reflexes. We are going to test the brainstem reflexes. What are brainstem reflexes? Anybody? Come on the mic again, please. What are brainstem reflexes? What do you test under the patient?
Cranial nerve reflexes.
Cranial nerve reflexes, correct? Yeah. So if there is cranial nerve reflexes, why don't you tell the family members that I'm going to test only those reflexes with which the baby is born? Only those basic reflexes of our life which we don't have to learn, which are normally given to us by birth, by life, by God. Those are the only reflexes which we test. If they are absent, that means the patient is no more. And those reflexes are present in the baby who is born at 1 second also, 1 minute of life also. And what are those reflexes? Baby can perceive pain. Baby breathes. Baby has a corneal reflex. Baby has a pupillary reflex. Baby has a cough reflex. Baby has a gag reflex. Baby has a vestibulo-ocular reflex. Baby has a doll's eye reflex. All these reflexes are present in the baby. If you explain this to the person that we are going to only test these primary reflexes of our life, and if they are absent, that means the patient is no more, the family will accept it better and you will accept it better as well, that yes, you have done the right thing. So how you communicate, how crystal clear you are in your thought process of explaining brainstem death to the family member actually determines how confident you are. If you join these two anecdotes of telling them what is life and breathing and how the breathing actually was the origin of the life in this person when the person was born, and now that the breathing is not there, ventilator is just an artificial machine. And if you talk to them about the reflexes, which are your basic reflexes with which you are born, everything else, laughing, smiling, reading, recognizing, looking here and there, we all learn as we grow up. But these primary brainstem reflexes are with us since we are born. You don't have to learn any of these reflexes. Nobody has to learn how to breathe. We breathe spontaneously. It's all spontaneous breathing. You cannot hold your breath even if you wish to hold your breath for a long time. At some stage, you will give away and you will start breathing. The family understands these things. It's about how you communicate with the family is very important. Just give me a second. I'm going to connect my laptop to an electric point. It's just showing low battery. Hold on. Okay. So tell me, any other questions? Did you understand what I just said? Or was I just passionately talking about it, not actually paying attention that whether you grasped it or not?
Yes, sir. Yes, sir.
Does it make more
Yes,
sense
sir, we
now?
got your point. Yes, sir.
Yes, sir. Yes, sir.
So never forget this. These are all buzzwords. These are communication which you will actually sometimes be doing in your life. Sometimes very often, depends on what unit you are working with, sometimes rarely. But if you explain it like this to the patient's family, trust me, there will be no family who would not understand it. What else do you want? Somebody else had a discussion about something, right? There was another question which had come. What was the question? Arindam, anything else you want me to discuss on? Counseling,
Yeah,
bad prognosis and medical error.
counseling, yeah.
Counseling, correct. Now, counseling is a very important thing.
Two things, bad prognosis and, sir, medical error or some iatrogenic complication.
Correct. So both things I will talk about. Bad thing is very easy. So first, principles of counseling. You have to follow some basic principles of counseling. Unfortunately, I may not have a presentation ready for that, but the same DCD presentation I can show because it had a part of it on counseling as well. Let me see. I'll bring it up. Okay. So forget about the donation aspect written in there. I'm talking about a general principles of counseling here. So a person who counsels, the most important thing is you should be open, you should be honest, you should be collaborative, you should be non-judgmental, you should be aware and comfortable in dealing with families in crisis. You should be trained and experienced to understand the conflict. You should be compassionate enough. And what are the principles with which you should do that? There are six principles of communication. So first is getting started, get your setting right. Do not do bedside communication, especially if you're doing a bad prognosis counseling. Arindam can tell the way we do it, and we do it in a very, very professional way. The second step is have all the information about the patient. Forget about the patient wishes here because I'm not talking about organ donation here. I'm just talking in general about prognosis. But even then, if the patient wishes were known that they would only have liked to live if their quality of life was good, it's an important wish to know. The third thing is how much has the family been informed up until now? And it is not about what doctors have spoken because doctors often speak very, very cursory language or they often use medical jargons. And it may not make any sense for a lot of patients, family members of what the doctor has said. They would just listen, but not react to it. Then you have to provide them information. In fact, in every conversation or meeting, which I do, the setting which I like to have is not across the table conversation. I would like to sit at the right angles with the patient's family. Because if I do across the table conversation where I am on one side of the table, they are on the other side of the table, it is a very, very confronting scenario. Whereas I sit on a side or if I have a round table, then there are no corners and everybody is equal. Then in that case, a conversation becomes good. Always have some water and tissues present. Always go in with your nurse. Better to have a female nurse with you, especially if you have a female family members. I would always insist on a female nurse to be there. If the bedside nurse is a male, I would still take a female team leader or somebody else with me to be inside with me, or I would have my coordinator. Fortunately, our coordinator for these communication sessions. One of them is a female, so we like to take the female with us because you need to have somebody on your side who would speak your side as well. And if it's a female, it's better. I always start off by asking, what does the family know about the patient? Before that, I introduce myself and all the team members, including the nurse. I tell everybody's role. I am an intensivist. I'm the chairman of ICU. He's the director of ICU. He's the nephrologist. He's the so and so. She's a nurse looking after. She's a nurse in charge. You've got to be very, very clear in your conversation of who has what and what are their roles. Then I often ask them, who are they and how are they related? I also ask them, are there any family members who are missing, who should have been a part of this discussion? And if there is a next of kin who is not there, or an important family member like a son or daughter or a brother or wife who is missing, then give them an option that would you like to take them on the phone right now and take them on the phone. Always inform them if you're recording the conversation that we are doing audiovisual recording of this. And then start off by saying that I would like to discuss about so and so and their medical condition. But before I start, I would like to know from you guys, how much you know and what is your understanding of the current medical condition. With that, you will know how much actually depth of information they have. And then you start providing a very honest understanding of the patient's clinical condition. Do not cook up stories. Do not give opinions. Do not say things which cannot be substantiated. Be as honest and as transparent as possible. And then I see what are the responses of the patient's family members. And then accordingly, I would say, if they seem to have understood it, what we are trying to say, then I would say that in medical opinion, this seems to be a futile exercise, or this seems to be very poor prognosis. However, we would like to continue for another 24 hours, or I would say that, look, even continuing for 24 hours is not going to help. Then the family may respond in two ways. Either we have to, is there anything else we could do? You've got to look into their eyes, have a good eye-to-eye contact, and should be able to say that everything feasible has been done. However, if you feel that you need to have another opinion or something, we are open for that. Always give that as an option upfront if required. Never shy away from that, because it is something which you are doing very transparently, very clearly. As soon as the rapport with the family is developed, you will find that the conversation becomes very easy and smooth. If this is your first meeting with the family, then I would say that take somebody with you who has already spoken with the family before, so that a continuation can be done. Or if this is right first meeting between anybody in the medical team and the family, let's say the patient has come and is very bad and you're doing a poor prognosis counseling, then you should be able to say in a very straightforward words that from whatever I have seen right now and the way this gentleman has progressed, prognosis is guarded, but it's only 24 hours right now. I would like to keep on trying, but it looks like that the patient is not responding to whatever treatment we are giving. And this is how I would put in the buzzwords. These are the words which actually help them to understand that the patient prognosis is poor. If you are very honest and transparent, if you have eye-to-eye contact, you do not put up medical jargons, you do not you do not try to hide behind the law, and do not take the side of the law saying that this is legal, this is what needs to be done. They don't want to hear any of that. All they want to hear is that have you put in a good effort or not? And if you have put in a good effort, what is the response of the patient? And if the response of the patient is not good, they will understand. Majority of them will understand. See, out of 100, 1 or 2 families will be unreasonable, and you will come across such unreasonable families. I'm not saying all 100% of the times will be successful. In those unreasonable families, you will have to just do multiple meetings. There is nothing you can do about that. And we do come across some families the last 27, 28 years that I've been counseling. I vividly remember 3 or 4 families which have been completely unreasonable and have put up demands which are not in sync with medical ethics, which are not in sync with any religious beliefs, which are not in sync with any normal behavior of a person. So you can't do anything for that. But 98, 99% of the families would they completely understand what you are saying and would completely agree to it. Similar situation goes when you have a patient who's had a medical error. Best is not to hide a medical error. Be as honest and as transparent and tell them what the medical error has been. And if you are able to tell that in a very simple word, trust me, patients will understand it. The more you try to hide, especially in the ICU of today, There are hundreds of people who are inside and outside the ICU who are exactly aware of what is happening. Nothing worse than you saying something wrong and trying to hide something, and then somebody goes and leaks out the information to them. So I would rather be honest. I may not give a very graphic and descriptive detail of what happened. Let's say a central line was put in and a pneumothorax happened, and it's a medical error. I would go and say that yes, a pneumothorax has happened. We had discussed about it before. We tried to be as diligent as possible. We used ultrasound. The person who was putting it was appropriately trained. But this is one of those things which are known to occur despite best of the care. Unfortunately, it has happened and we are going to take care of it. And we will try and improve the situation from here on. And we are sorry for what has happened, but this was despite best of our efforts. Um, patients get thrombolized and they land up with an IC bleed. We talk about risk of thrombolysis as 5%, 6%, 3%, based on various studies that we have. But when it happens to that person, it's 100% for that person. It doesn't matter if the 97% of the patients did not get it. These 3 people got it. That's more than enough for the family to be upset about. So never ever try to hide things. Hiding only becomes difficult to actually cover up. To hide one lie, you will have to speak 100 other lies. And if caught, you would lose the face in front of the family. You would lose the face in front of your colleagues. More importantly, you will lose the face in front of the hospital. At the same time, do not be abrasive and say something which will put you and the hospital into a difficult situation. You will have to choose your words. Be honest at the same time. Be in a considerate and a gentle way. Tell them that these are things which happen despite best of the planning. If you are able to convince that to the family, majority of the times they will take it in the right stir. Yeah, somebody in the family will come up and say that I'm going to sue you, and you should not get perturbed about that and say that, yeah, do whatever you want, or no, I know, blah, blah, blah. Don't try to sort of cover up again. I would say, yes, that's your right to sue, but I can assure you that everything possible to prevent this was done. And now that we have recognized this is a complication, we are trying everything possible to correct the problem which has happened. So if you are able to say this very honestly, trust me, majority of the people are reasonable. They understand it. They would not create a fuss. 2 years down the track, 1 year down the track, they may come back hunting for it. Possible, I don't deny it, but majority of them would not. But you never know, somebody would. So best is not to hide it. Be very honest and transparent. Arindam bhai, anything else?
No, boss. I think if there are nothing from the candidates, I think we have more or less covered.
They have not been speaking up. So I am feeling a little one-sided that am I just speaking to...
Good evening, sir. Hello.
Ron.
Yes, sir. I'm Ronak from Gujarat. So, sir, regarding the bad prognosis or a long-term prognosis in stroke patients, if there is a lots of if and buts in the prognosis in a long-term ICU care, so can we in the first meeting or second meeting have to counsel the relatives regarding all the possible ICU related ifs and buts, or it will show less confidence in us if we show all?
No. So it would not actually, it would show you into a very good light, and they would appreciate it. So what I usually do is that when you have a head injury or a stroke where you don't know how the neurological prognosis is going to happen, and the patient may be on a ventilator or maybe bedridden for a long time, I would start by first saying that in neurology, it's very difficult to actually prognosticate accurately. And hence, in various clinical conditions in neurology, there are various timelines which we wait till we start saying that this seems to be the final recovery. For example, in a ischemic stroke, you would want to wait for 12 months. In a hemorrhagic, sorry, so 6 months. In a hemorrhagic stroke, you would want to wait for up to 12 months. In a anoxic brain injury, again, 3 months to 6 months. In a head injury, I would wait up to 12 months. For diffuse axonal injury, I would wait for 12 months to see the final prognosis. I would say that while we are giving this patient time, there are certain things which we need to be careful about. And despite best of the efforts, sometimes you do land up with some complications of a bedridden patient. And some of the complications of bedridden patient could be infection in the lungs, infection in the urinary catheter, or if you've got central lines or peripheral lines, you could have an infection of those lines and leading to infection in the blood. Similarly, decubitus ulcer, or you could have pulmonary embolism because the patient is not moving, contractures. All these are possibilities, and assure them that we are doing everything and tell them what you are doing to prevent it. DVT prophylaxis, beds, frequent change of bed of the position in the bed, air mattresses of the best quality available in the market right now, the physiotherapy so that contractures are not developed, looking out for actively infections in these patients, doing infection surveillance, changing the lines as required, keeping an eye on the biomarkers for infection. I think if you explain them that these are things which we routinely do, looking for infections, looking for embolism, preventing embolism, so on and so forth, I think they would actually appreciate care and say that, look, these doctors are thorough. They are not just treating the present, but they are actually knowing what to anticipate in such patients, and they are taking preventive actions for that. So it is how you put it, Ronak. It's about crystal clear communication is how you put it. If you put it in a very nice way, in a way it would actually put up a positive impact, patients would be appreciative, families would be appreciative of your patient care.
Yes, sir. Thank you, sir.
Okay, guys, I think we've talked about a lot about it. If there are no more questions, then thank
Sir,
you very much.
sir, sorry. Sorry, sir. Sir, Rohan here.
Bolo,
Sir,
Rohan.
just one question regarding the antemortem cannulation in a DCD patient. So, sir, is it legal right now in India to do it? If suppose there is a brain dead patient and
Cannulation, you can do it, provided you take up a consent for putting a guide wire or a sheath antemortemly, so that post-mortem you can actually use that as a cannulation process. So you will have to go through the same consent process as you would take it for any other line or any other procedure you do. So there is nothing illegal in that. You just do it as a process of putting a line in. I would not put a ECMO cannula antemortemly, but I would definitely ask for a family to put in a femoral arterial and femoral venous sheath, so that if and when the death happens, I just float a guide wire through that and quickly dilate, take out the sheath and quickly dilate it and put a ECMO cannula. That should be done within 5-10 minutes if I've got everything prepared. So it's nothing is illegal in that. You can definitely do that.
got it, sir. Okay.
One, we are far away from this. So don't get fixed on DCD. Don't get influenced by organ donation. Don't get influenced by transplant teams that this is the way out. I think all of you who are young, who are actually will be the torchbearers in future for the critical care, should master brainstem death first. Only when you are confident about brainstem death, you will be able to think of DCD. And before you do DCD, you should be extremely comfortable withdrawing life-sustaining therapy for the lack of outcomes or futility, for example. In that case, only in that case, when you are comfortable, you'll be able to talk about DCD. Otherwise, you'll find yourself in a fix where you're not able to communicate crisply, and you will find yourself in a position where people will start doubting your intentions. The last thing you want is that you're withdrawing therapy on somebody, and in the same breath, you're saying that, by the way, we can also donate organs. So they will only construe in the fact that you actually want to withdraw for organ donation only. So never ever should that thought process come in. Our duty of care is towards the patient. That patient is suffering, has got no foreseeable recovery, outcome is futile. As a doctor, you are saying life-sustaining therapy may not be useful. Do that many times, withdraw the therapy many times, using the Supreme Court judgment, the way it is written, to the rules, to the books, and then organ donation will automatically become a byproduct of it after several of them, not on the first of that. Thanks.
Thank you, sir.
I think for the sake of examination, I think donation after brain death is most important. DCD, we just wanted to give you guys an idea that this is happening in certain places and very far and few though. And we are not very clear on the legalities, particularly in the private sector. and very unlikely there would be in a practical examination, there would be situations where you would be asked it. But it's good to know about it. That's it. So, but you would definitely have communication scenarios. So brush it up. And as Dr. Pandit guided, you have to have certain both verbal and non-verbal communications, and all those things would be it. So, Sudeshna, is it tomorrow Darshana is taking the class, or are we
Yes,
going
sir.
to announce?
It's
So,
tomorrow around 5 o'clock.
so 5 onwards tomorrow we will have a quick session uh, on mostly on the quality aspects of care, patient safety, conducting clinical audits, and a little bit on the accreditation, the NABH, maybe just an overview of JCI. Almost both are same on that part, and if there are any. As also, as Dr. Pandit repeatedly was requesting you guys to respond, it would be nice that if you can put up your questions, because more you put up questions, we have opportunity to rectify and you learn from it. So don't forget, almost 15 marks is being allocated for this specific the quality aspect of it, and another 15 for the communication and ethics itself. Bala definitely has covered well on this, on the how to study a review paper, and obviously you are the best person to know about your own thesis. So all this will cover your 60 marks on that. So all the best. We will meet tomorrow 5 onwards, and then straight to the on the mock test itself. Thank you. Good night. Have a great week, Sunday evening. And most importantly, thank you, Dr. Pandit, for sparing your very valuable time, and almost you spoke for close to couple of hours. And it was a very enlightening for all the students itself. So good night, all of you. Thank you, sir.
Thank you very much, guys. Thank you. Have a good day. Bye.